So how was your trip to Toronto?
My trip to Toronto was incredibly flawless. Flights on
Oh,
time. 2
wow.
flights. It was shocking.
Welcome to Health Signals, Episode 3, the podcast where insiders in healthcare help you understand whether or not what you see in the news is a signal or a trend in healthcare and beyond. I'm joined by co-host Katharine Smart, past president of the CMA and one of Canada's 100 most powerful women. I'm Alika Lafontaine, also a past president of the CMA and a past Maclean's top healthcare innovator. So we usually do a video podcast, but both Katharine and I have been traveling over the past little bit, and internet's inconsistent. How you doing there, Katharine? Where are you at today?
Oh, I'm great. Thanks, Alika. I'm back in Toronto, here for a board meeting with Ronald McDonald House Charities, a program that's really near and dear to my heart as a pediatrician. So we have our board retreat tomorrow. So I just got here this afternoon. Where are you?
I was in Halifax yesterday, just on a day trip.
Saw some things about your talk on X. Looked great.
Oh,
That's how I know where you are, Leek. I stalk you on social media.
I have done that to you as well. So what have you been up to the last couple of weeks?
Well, I actually just had a small surgery. I found out this would be important for our listeners so they can, make sure that they're looking after themselves. I found out I had skin cancer on my nose, and I had
Oh, wow.
it removed last week. But, I would also say shout out to our public healthcare system, how smoothly it went for me. I got in Kelowna. There's a skin cancer center that's the doctors there are family doctors that have extra training in dermatology. So I got in with one of them and got great care, and they had all the right equipment and were able to figure out what was wrong with me. And then I was able to actually have it removed there the next day by a plastic surgeon because they had a cancellation. So, I got in within a few weeks of being referred and had my surgery right away. So I was really grateful for the care that I had. And just a reminder to everyone listening, if you've got any unusual looking things on your body, make sure you get someone to look at them. But I was really grateful just for the care I got. And, sometimes even though you and I tend to talk a lot about things that don't work, there's lots of great things about our system that do work. So I was happy to be on the receiving end of that experience. To access is getting through that front door and getting to your place in the queue, right? And once that happens, I think often the care is really exceptional. But there's just, as we know, too many people waiting often too long. So I was very fortunate. What have you been up to, like, the last couple of weeks?
Last week we had the Canadian Medical Association annual general meeting. So we did the official turnover of presidents.
Yes.
This year we shifted the meeting from in the summer to the fall. So for the first time in CMA history, we have co-presidents, Dr. Joss Reimer and Dr. Kathleen Ross, who continues being president for the next few months as they kind of have their turnover. I'll remain in the past president year into the summer, but come August it'll be back to the regular rotation. But I'm pretty excited for them. If we ever needed two presidents of the CMA, it's right now.
Right? Oh gosh, so true. Yeah, it's exciting to see. And it's always exciting, I think, when new people come on, new energy. And, Kathleen's been working really hard this year, and it'll be great to see what Josh brings to the role. Lots of important conversations happening, which probably leads us into what we want to talk about today.
We're going to start off with a couple of good news stories. Both are actually from Carly Weeks. She's a reporter over at the Globe and Mail, been there for 15 years. Carly is actually moving on from the Globe and Mail. She's becoming vice president of communications, public affairs, and stakeholder relations with St. Joe's Healthcare in Hamilton. Folks may wonder why, when we read through the news, we always make sure to talk about healthcare reporters who are on their beats. I think one of the big reasons is folks who've been in the game for a long period of time help to unwind and unwrap stories in ways that are nuanced and have a lot of depth. And I think that's one of the challenging parts with healthcare stories is that, when you read it, you kind of get caught up in the acuity of what gets reported instead of seeing kind of what's underneath. And I think Carly has done an amazing job with that over the last, 10 plus years.
I totally agree. And I'm sure you had the experience of being interviewed by her many times too while you were CMA president. I certainly did. And I agree. I think she asks great questions, has great insight, and has been around long enough to really understand the complexity of a lot of the issues. So I always really appreciated my conversations with Carly, and I think she's really brought a lot to healthcare reporting. So she's a big loss.
we'll move into our first story. It's titled Sick Kids Lowers Surgery Backlog Through Successful New Partnerships with Nearby Hospitals. This was published from the Globe and Mail by Carly Weeks in the week of May 27th. Toronto's Hospital for Sick Children, Sick Kids has successfully reduced its surgery backlog through a new partnership with 6 nearby hospitals. This initiative, which involves transferring less complex cases to partner hospitals, has resulted in a 10% reduction in the surgery waitlist over the past 9 months, bringing the number of children waiting for surgery below 6,000 for the first time since November 2022. The program, which also includes performing non-urgent surgeries on weekends, has led to nearly 700 referrals and 320 weekend procedures. This collaboration and innovative approach is one of many key steps towards improving pediatric healthcare accessibility in Canada. When you read through this, I mean, this is a good news story, Hank.
Oh, absolutely. It's a good news story, I think, in so many ways. I mean, of course, all these children who've been waiting that finally got care, I think that's incredible. But I also just love the collaboration and the, innovative mindset about, okay, here are our resources. How can we use them optimally and getting outside the box a bit, right? There's a lot of skill outside of major tertiary hospitals that can be mobilized. And I think this story shows that they were able to do that. Of course, we want to make sure the right people are getting care in the right places, but a lot of children can have care outside of children's hospitals, especially when supported by the Children's Hospital. And I think that's what Sick Kids has demonstrated here. So I love that direction. I think that's really fantastic. And then also, looking at this really valuable resource, the operating room, which of course you would appreciate being an anesthetist, are we optimally utilizing that as much as we could be? Is it running as late as it could? Is it being staffed after hours on the weekend? And are those opportunities to get more people through? And how can we optimize that? And when I had the opportunity to work in Australia, and it was really interesting there because they ran their ORs, their elective ORs, more on shifts in some situations. So they would have sort of a day shift, which is our traditional time in Canada, like 7 to 3. But then they'd also run a room like 3 to 7 or 3 to 10 each day. And they did the same with their diagnostic imaging. So it really allowed them to take what is a scarce, highly skilled resource and optimize the use of it. Now, of course, you have to have the right amount of staff for that, so you're not just burning people out. But I think it's this type of thinking that's going to be really important if we want to address backlogs. And we certainly know that there's huge issues with access in pediatrics. In fact, children often are waiting longer than adults for surgery and diagnostic imaging, which I think would shock a lot of listeners. So this innovation, this collaboration, this partnership model that we're seeing emerge here in Ontario, I think is really exciting and kind of gives us hope that we can solve some of these problems with the resources we have if we just choose to work together.
One of the things that really stands out to me in this news story is that it was a partnership with 6 nearby hospitals. I mean, you can decrease the amount of folks that you have on your wait list by putting them in other places where they can get quicker care. You can also do it through doing higher volume, which actually happened in this story as well. I attended a talk with Brian Goldman. He's the host of White Coat Black Art. Folks have probably heard him on CBC Radio. Both of us know Brian from interviews and other interactions. But he presented on teamwork, and he talked about this board game called Friday Night at the ER. Have you ever heard this?
No, I haven't. Tell me.
Yeah, so it was a fascinating presentation because he talked about the game and how a lot of health management organizations in the States uses this to communicate to people that as you're kind of playing the game. So Friday Night at the ER is a game where you're in charge of one part of the hospital, and as you're garnering resources for what you need, the other 3 players in the game actually start losing. So it's to communicate that in the healthcare system, when you have scarce resources or resources that aren't so plentiful that you can really dial up activity, when you take and do better for you, the other people suffer. And I think that this really gets communicated in stories like this, where you had Sick Kids working with other hospitals. If Sick Kids simply increased the amount that they paid staff, tried to bring more staff from other hospitals into Sick Kids to do this sort of work, all that would happen is Sick Kids would benefit and the other hospitals would suffer. And this is the state, I think, of most healthcare systems across the country. If we approach things from a siloed sort of way, it'll be good for us wherever, you're working, but it'll be bad for everyone else that gets negatively affected from those resources flowing from there into whatever hospital you're trying to get resources for.
Yeah, no, it's true. And I also think, certainly for myself being a rural provider, I also think there's this huge missed opportunity by not seeing colleagues outside of tertiary hospitals as potential partners, right? Because there's a lot of amazing physicians and amazing teams that exist outside of tertiary centers that with some support can actually execute at a really high level. And I think we have to caution against over subspecialization, where we aren't maintaining people outside of big centers with skills, because I don't think that's sustainable. And I also don't think it's always actually what's best for patients. So, I've certainly had the experience in the Yukon of caring for kids with complexity with the support of subspecialists in pediatrics and doing procedures and, infusions of special drugs and starting, unusual treatments, but at home for people with that support, we've been able to sort of elevate what we're providing, things that wouldn't typically be done in a rural place. And it's been really powerful. It is a provider, like to be able to upskill and feel supported for the families who are getting care close to home, which is obviously preferred and not having to travel. And I think also, for the people in the bigger centers, they get that opportunity to be teachers, to support and to see that they can encourage that skill development, which ultimately benefits the whole system and improves access, like we've been talking about. So I think there's wins there for so many reasons. And I love every time I get to be part of those types of collaborations, because I feel like, yes, this is what we should be doing. And I also think it makes sure that the right people are getting the right care in the right place. And the more we can support people outside of big places to do more, I think the more we can execute for people across the whole country. So I love seeing this way of thinking. I think it's the way forward for sure.
If you approach problems in that way and, really remove those speed bumps that are in places patients trying to get towards the care that they need. I'm reminded of midwives who work in our hospital who refer directly to anesthesia for epidurals. What used to have to happen is a patient would need assessment by an obstetrician or a family physician. And then as a result of that assessment, we'd then get referred to by the MD. Folks looked at that situation and realized, we're probably doing redundant care. The midwives have the skills to assess these patients. There's no reason why anesthesia can't interact directly with them. And that shortened the time to treatment for patients in need of pain relief, as many listeners who may have gone through pregnancy either as the person who was pregnant or the person on the other side supporting them. That time to treatment is really, really important. And your story about treatment of the skin lesion, I think really illustrates, you have a family physician who has specific skills in the area of dermatology. They're working with folks who can actually solve the problem of how to excise that skin lesion and just consulting plastics directly instead of having to go through, multiple different layers of decision making. I think that is really where team-based care that gets patients to the care that they need in a faster, cheaper, more pleasant sort of experience, which I think at the end of the day is the kind of system that we all want to work in.
Yeah, I totally agree. And I also think, my own experience as a specialist, but a generalist, right? I'm a general pediatrician, so I practice across the scope of pediatrics. So even though I only care for children, it's really quite broad. I've had that same experience myself, right? I've developed a lot of different new skills over the last few years since working in the Yukon, where I'm doing things I didn't do before. And because I've been supported and mentored in those, I now feel like I can provide really quite a high level of care for patients for things that I wouldn't have been able to do before. And if they weren't getting that care from me in the Yukon, they'd been waiting months and years. And I think, one of the best examples of what we've done is our autism program. We had kids waiting years and years to be seen in either British Columbia or Alberta to be assessed for autism, because of course the waits are really long everywhere because they weren't happening for school age kids in the Yukon. They were happening for younger children, but not school age children. So we recognized,
Okay.
that this was an issue, for our patient population, and it was pretty clear that we needed to solve that ourselves. So I went and got those additional skills, and we've been providing that service now and diagnosed a lot of kids, and I love it, right? Because they're getting assessed by a local team, so the family's getting follow-up with those same people. The resources we're recommending are appropriate and available where we live. And sometimes the challenge when people get care outside is they come back with recommendations that actually can't be followed through on where you are. And we've also built again our team within the territory, upskilling everybody so that we can do, I think, a really excellent job for these families. So again, I think there's something to be said, family doctor with extra skills in derm, pediatrician developing extra skills in developmental pediatrics or mental health, which are burgeoning areas in pediatrics, so that we can meet those needs ourselves. I think that's, again, it's got to be the way forward, right? Not everyone can be referred to a subspecialist, and lots of these things can be provided very competently by people when they've gotten extra training and support and they have access to mentorship. And again, I think we almost need to pull back from this subspecialization to embracing, high levels of generalism with extra training for special areas. I think if we want to really be able to reach all of our patients, because I certainly know if we weren't doing that, all these kids would be sitting on a wait list, and that's not serving them or their families.
And I think that's where the whole discussion around complexity started off. Things were getting more complex. There was new types of equipment, new types of medical conditions, new types of medicinal interventions. And so you had to sit through, a more formal type of training because, people were bringing in laparoscopic surgery, for example, like using cameras to take out gallbladders instead of making a large incision. It was a big change in how people practiced and did care. But I, just like you, I think people have leaned in too much that if anything is different, suddenly we have to create a whole new module or new set of training approaches in order to get people upskilled to the point that they can do things safely. Like what matters the most, I think, is that when a patient comes to see you as a provider, whether you're a physician or a nurse or nurse practitioner or a pharmacist or a physiotherapist or whomever you are, is that the care that you provide is up to the standard care that folks in your position would do, and that it actually helps solve the patient's problem. You nudge them along their diagnostic pathway, their patient journey towards, either getting their problem solved or getting into that cycle of having the system do what it needs to, and then you go back to your life and then you come back again. But the end goal, I think, of dealing with complexity is actually solving people's problems. And I feel to a great degree we've lost the plot when it comes to that.
I agree with you. And I think it is because we have, in some cases, gotten overly specialized or sort of started to believe. And sometimes patients, I think, struggle with this too, right? There's perception that seeing someone more specialized is the solution to their problem. And of course, sometimes that's true, but often it's not true. And I think that, another great example of how I think we're leveraging access to improve skills is like the eCase program in British Columbia, right? You can connect with a subspecialist over this secured messaging platform where you tell them about your patient and they give you advice back. And I've been able to access that for a couple of my patients recently with pediatric gastroenterology. Well, they have a 2-year wait for in-person problems, but I can get a response back from them in a couple of weeks where I'm able to say, hey, these are the things I'm thinking of. Am I in going in the right direction? Am I missing anything? What do you think? And they can come back with, hey, do these next 3 things next. Okay, well, what a win, right? I've done a very thorough assessment. I've provided them with a lot of information. I've kind of gotten to the end of what I know. I'm looking for a bit of support and direction. They're able to come back to me, provide that. I'm able to go back to the family with next steps. And we may solve this person's problem, 2 years ahead of when we would have if they would have had to wait for that in-person appointment. So I think there's so many examples right now of how we're leveraging different situations to do what you were just talking about, right? Trying to get people to a solution faster. And I think it involves all of us being willing to provide advice, step out of our comfort zone, learn, develop our skills. For people with extra specialization, being available to provide that support to people who are more generalized, and that interchange, right, of experience and knowledge. I think that can really expand what we can offer people. And to me, I think that's the beauty of technology now, that it allows that more easily. And I think these are all the things we should be leveraging in our system to really improve access for people. And again, getting problems solved, not just having people on wait lists. So I think there's lots to be optimistic about, but we've got to make sure that we're really, executing in all arenas, I think, to solve our access problem. That's for sure.
This takes us into the second story for today. Toronto hospital program aims to improve care for at-risk patients with dedicated health team. This is also by Carla Reeks over at the Globe and Mail, published the week of June 4th. And, just a quick rundown of the story. Toronto's University Health Network is launching a new program to improve care for at-risk patients by pairing them with a dedicated health team. This initiative, led by Gattuso's Center for Social Medicine, involves nurse practitioners and social medicine navigators working together to provide comprehensive support including access to healthcare, social services, and transportation. The program targets individuals with high healthcare needs, such as frequent emergency room visitors, aiming to break down barriers to care. While it can't solve all systemic issues, the program seeks to make a significant difference for some of the most vulnerable patients in the community. What's your response to the second story?
Oh, I love this initiative as well, right? Again, I think it's that recognition that for so many folks, their health problems come from their social marginalization, right? Perfect example is people who are unhoused, right? You maybe have a mental illness or you have addictions and you're unhoused. Our thinking has always, I shouldn't say always, but often has been, well, we have to get people well first and then find them housing. And all the evidence is telling us the opposite. No, you got to get people housed, then you can work on these complex problems, right?
Mm.
And I think this recognition that we need to address underlying social challenges first, get people stable, make sure they're housed, fed, safe, is instrumental before we can move further down the path to treatment and healing. So I think these types of programs that are really recognizing that, and then putting the team in place to get people those right supports and to support and encourage them is so important, because in reality, there are a lot of social programs available, but they're not always easy to access and can be quite challenging. And again, we have this sort of assumption that this is something people have to be able to do completely on their own, and it's not always realistic. In our clinic, we have a social worker who's working in that role as a patient navigator, and I can tell you it's been game changing. It's game changing for me as a physician, because when I encounter these situations, I have a colleague with more skills than I have in that domain who can connect with that family at the intensity they need to be able to get these things in place. And it means that people are getting way more services in a way more timely way than they would get with me just saying, oh, go do X, Y, Z, right? Because for some folks, they need more support than that. And I think when you look at, emergency department utilization, people that end up in the emergency department a lot, it's usually not because of health, direct what we would think is classic health problems, but it's usually more to do with the underlying social circumstances that have never been solved, right? So again, we're coming back to that theme of how do we solve things for people. So I think starting to expand that lens on what is health, what is healthcare, it's also health and social care, to really care for the most marginalized in our societies. I think that's the path forward, and it's great to see different thinking, leadership, but most important, resources, right? Because it's all great to share those values, but if you don't resource them, you're not going to see impact. So I think programs like this are hopefully going to really prove to people that yes, this is where we should be investing and making sure that we're not forgetting about these really important things. What was your take on it?
There's two things that kind of jumped out at me. I think when we talk about team-based care, sometimes we can get taken into a side conversation where we're not actually talking about team-based care. We're talking about switching out whoever used to give the care for someone else, right? And so most of the time, this ends up being family physicians or MDs doing something, then replaced by, a nurse practitioner or a pharmacist or whomever. I think what this story shows is that it's actually about the team. Like
Yes.
we don't need to switch out the title. What we need is people actually doing the work, right? And that's something that came out pretty loud and clear in this news story. And I think in well functioning teams, it's not that titles don't matter, because titles are linked to legislative authorities to provide certain types of procedures. They're tied with certain types of training and other things. But when you're at the interface of providing care to someone, what matters less is not your title, but it's can you actually solve stuff? Can you fix the problem of the person sitting across from you? And in certain situations, it's going to be a surgeon who can perform some sort of complex procedure. Other times it's going to be a social medicine navigator who's going to take you through different programs, so you can get the other things that you need for help that have nothing to do with having that surgical intervention. And so I think that's one thing that really jumped out to me from this news story. And I hope with team-based care, we can start leaning more into this idea of what do we literally do, and does that provide value for the person sitting across from us, instead of getting caught up in this social hierarchy or these outdated decision-making models where we ask two people who tangentially are involved in whether or not a patient can get better, but we still ask their opinion because that's the way we always did it. The other thing that I think is really valuable from the story is thinking through, like, what are we actually trying to achieve when it comes to healthcare costs? Because I think the focus over the past, decade plus has really been on austerity, right? Like, what's the
Mm-hmm.
cheapest way for me to provide this service? And so people have been obsessed about penny pinching, let's get rid of this or that because it's not directly related to what the patient needs or can be provided, when I think there's probably a lot more cost saving if we can redirect people to cheaper services, right? It's very expensive to get treated for, something like sepsis, overwhelming infection of the body requiring IV antibiotics plus minus, surgical debridements in order to take away infected tissue. But if you can get someone housed, if you can get someone taking oral antibiotics early in their care, if you can get someone walking people through the mechanics of why they need to take things certain ways, the benefit that it has for them, having them connect with some sort of community that will provide mental health support as well as, navigation and information when people have questions about exactly what's going on. Those aren't as expensive as, staying up all night, taking out, a large infection, which I think both of us have been involved in those cases. I
Oh,
think one of the
100%.
one of the longest surgeries I was ever a part of was irrigation and debridement. So they opened up the wound, they cleaned it out with fluid, and then they started to take away infected tissue. I mean, there was one case we were in there for 4.5 hours.
Yeah.
And this was a patient who lived alone in a remote place, didn't have access to clean water, and infection just started to spread. It wasn't their fault. They just didn't have access to a lot of things, and I don't think realized just how dangerous things had evolved. Now, if someone had been there to intervene earlier, if we made it easier for that person to connect with someone in the healthcare system who could give them good advice, it doesn't need to be a doctor. It could be a lot of different people. I think we would have walked away with, cheaper cost, a better outcome for the person. They could have avoided a lot of follow-up surgeries. And I think moving towards team-based care, looking at what you've been talking about, as well as the things that I've just been talking about, I think that'll get us closer to what governments actually want, which is cheaper, more effective, high-value care, than simply looking at how can we switch out a title or how can we cut costs by kind of iterating around the edges.
Yeah, no, I agree. And I think the other key part of this, right, is moving some resources upstream, right?
Mm-hmm.
And recognizing that to address people's health in the, what we traditionally mean by health, which is, keeping them free of disease, means that they need these basic things, right? And I think that's why we're seeing evidence starting to come out around things like basic income, universal basic income, housing, et cetera, is what we recognize is ultimately those things are much less expensive than people being sick. And I think that's also where we need to shift some of our thinking, right? Is what are we actually doing to help people be well and healthy, rather than just trying to, save them, like you were talking about, once they've kind of fallen off the cliff, right? How do we keep
Yeah.
people up on the hill so they're not falling down to the bottom? And I think, because our system generally has been so illness orientated, and we also have a real sort of bias towards sort of rescue type care, we're often not investing enough on those other pieces that would have helped people stay healthy in the first place or gotten them care earlier. And I think some of it is it's less sexy, it's less exciting, it's more complicated. But the reality is, even this idea of, can we help people navigate to services that already exist? It may not even be
Mm-hmm.
creating new services, but it's making sure people are actually accessing the things that they should be accessing that are already out there. And that's what I've found through our clinic. So much of the time it's not that we're creating new things, it's that we're actually making sure families get access and the follow through of things that already exist and that they should be accessing, but they just needed that support to close the loop, right? So I think that's the part of, what's so important when we talk about these things is sometimes it just takes a bit more to get people there. But when we do that, ultimately it keeps them healthier, and that saves, dollars. I mean, of course, equally important is what it means from an ethical perspective, I think. But if your
Mm-hmm.
main concern is budget, then yes, that's going to be the answer there too, right? So it's really a win-win, I think, no matter your point of view. And I think this is like the learning that we really need to embrace as we move forward.
I really feel, and we've talked about this before, that we're probably at the beginning of a new arc in healthcare.
Mm-hmm.
If you go back quite a few years to when wait times were first being talked about in Canada, those conversations actually started within the Canadian Medical Association and then filtered up to policymakers. People leaned in. Suddenly there was a Wait Times Alliance that brought together folks from across the country. Provinces and territories had a lot of pressure from the federal government to commit to decreasing the amount of time that people waited for surgeries. Suddenly everyone was working together. And I think for a period of time in the late 2010s, many of us thought that things were going to turn a corner, and then everyone just stopped talking. All of these collaborative spaces that we were working in were wound down and shut down. And as a result, folks started to really struggle, because when you're by yourself, just like in that game, Friday Night at the ER, you don't realize the negative effect that you're having on the people around you as you're trying to fix your problems by taking away from other folks and what they're trying to build. And so I think with this reinvestment of healthcare dollars, the federal government in 2023 had the largest injection of healthcare dollars into public healthcare that's happened since 2004. You were part of laying down that runway when you were CMA president. I continued on with that. Kathleen has been a big part of making sure that the bilateral agreements, which were a big part of that funding, having every province and territory sign an agreement with the federal government as far as targets for how the money is going to be spent and seeing whether or not it's going to be effective. That closed off this year. I think we're moving into what could potentially be a shift away from all the really negative stories that we see in healthcare right now. But it is going to take a bit of time, and it is going to require people to move away from the ways that we've always done things.
Yes.
Truly moving into team-based care, getting away from hospital-centric, MD-centric, or just some sort of provider like nurse practitioners only working with nurse practitioners, or pharmacists just with pharmacists. Like we have to blow up that siloed, quote-unquote, team structure. We have to start working together, and we have to be focused on people and whether or not they are getting what they need, and if the person that they go to actually has the skills and the talents to provide that care. I hope we move into those discussions.
Yeah, no, I agree with you. And I think you're right. I think we are seeing some of that shift. I mean, even the bilateral agreements, when you really think about it, sometimes it feels like change is so slow, but that's actually huge, right? That's a big shift in the relationship between the federal government and the provincial government when it comes to healthcare spending, setting priorities, getting people to agree to them. This is actually a really significant change. And I think it does set the runway for more transformative change. And I love this quote, and I think it really applies to the healthcare system right now, is if you want something you've never had, you've got to do something you've never done. And I think that is really where we are, right? And I think people are waking up to this reality that more of the same is not the path ahead. We've got to, keep the things that work well, but we've really got to fundamentally shift in other spaces. And I think that that idea of integrated team-based care and really being able to expand our reach through that is so critical, because we're not going to be able to just train our way out of this problem. We've really got to task shift what people are doing in a meaningful way, like you were describing, and using, like, another great example I think is AI. I've started using an ambient scribe in my clinic. Well, I mean, game changer. All of a sudden, hours of notes that I would spend typing out at the end of the day are generated right there on the spot for me. I mean, this is giving me back hours and hours of time. That means I can see more patients with more complexity because I'm not, spending as much time. Obviously, there's still some time, but it's really cut that down. So I think that, there's things that are at our fingertips right now. I think that it can really create scales of change that we couldn't really imagine before. And I think we're moving in that direction. So I think there is lots of reasons to be optimistic. I think sometimes it's hard to be patient, and I know I struggle with that myself. Like, when you see these big problems, you just want everything to be better right away. And, of course, we know large scale change never works like that, and bringing people along is a huge part of it, and managing people it does take time and trust. But I think we are seeing shifts in how people are thinking, and I think, that more and more there's this recognition that, hey, all these new things that are going on, there's a huge opportunity to really do things in a different way, and I'm hopeful that we're going to be seeing that come to fruition here in the next years. Also, thanks to everyone who listened today. Always interested your comments and suggestions, and hopefully you'll leave us a comment below. And what I would also love to hear from our listeners is, what are topics you'd like to see us talk about, or is there any news stories that you've seen that have captured your attention that you would like us to take you behind the scenes on?
With that, we'll wrap it up.